As all of you know, the cancer survivors are increasing. We have made a lot of strides in the cancer world because of better treatments, better radiation therapy, improving bone marrow transplant, and many other areas, immunotherapies, CAR T cells, etc. There are more than about 43 million cancer survivors globally. And all of us are going to take care of them. Not the psychologists, not the psychologists, not the cancer oncologist or hematologist. Primary care, everybody who's listening will undergo some encounters with the cancer survivors because there are so many. And once they're out of the treatments, we will see them. All of us will. Thank you. I can see the slide set. We can go to the next slide. All right, no disclosures. Holistic care I described earlier on, so we can go to the next slide. As I mentioned, 43 million survivors globally. This is 2018 data, and we all have to take care of them. And the problem is that a lot of them, after the treatments are done, are living through a lot of disability. As you know, that the WHO's disability list, the top two problems are blindness and depression. A lot of cancer patients also suffer from a lot of depression, anxiety, and other problems in long term, let alone the other problems that happen with toxicity of the chemotherapies, immunotherapies, and radiotherapy. So let's talk about Shirley. She's a patient from Ghana in the UAE, and she was diagnosed with multiple myeloma. She's a 39-year-old mother of two, 10-year-old, 16-year-old, two boys actually, live in studying in school in Sharjah. She's ex-smoker, divorced. She's from Accra city in Ghana. She had pneumonia. She was admitted a couple of times, got IV antibiotics. Most of the pneumonias don't get actually admitted in young people if they don't have risk factors. The second admission, she had a lot of pain in the back and was found to have fractures, osteoporotic fractures of the spine. Did the nuclear scan and clearly indicated a lot of osteolytic lesions. Was diagnosed with advanced cancer, which is multiple myeloma. As all of you know, it's a blood cancer. She got many cycles of chemotherapy, 4 cycles for 4 months. Stem cell transplant was indicated. After 7 cycles, stem cells were collected from her, and then she got a transplant. I'm not going to go into the medical details in the interest of time, but after transplant, she got further chemotherapy for maintenance so that the cancer doesn't come back. She also planned to marry again, she told me one time, but she had some history of intimate partner violence in the past. About 4 or 5 months post-transplant, she had a relapse of the cancer again, coming back. She got chemotherapy again and was going to go for transplant. That didn't happen, but again, at 600 days after transplant, she got another relapse of the cancer. So basically, cancer keeps on coming back and back and back, and that's the nature of the disease. That once the blood cancer gets diagnosed, we tell the people that it's the recurring cancer, like it will keep on coming back despite all our efforts. She had a second autologous stem cell transplant planned. This is a bone marrow transplant. The allogeneic transplant person to person was going to be a last resort. CAR T cells and other immunotherapy not available in the UAE. But she was asking that, can I ever have a break? She lost a job. The kids were not going to school because they had a lot of problems in school. So she's an older kid. She was bankrupted, socially isolated, lost a job. As I mentioned, unemployment was another stressor. Does not want to think about myeloma anymore, but she can't stop avoiding that. As you can see in her picture, she has aged very quickly, and that's what happens with chemotherapy and radiation and transplant. They age at an unprecedented biology. Which cannot be matched, and that's why people with radiation chemotherapy they develop the heart failure, dementia, all these other problems very early, much ahead of the peers at the same age. Antidepressants were started for presumed major depressive disorder. Counseling was suggested. Deficiency of psychologists was there. Dr. Kashivagi mentioned the number of psychiatrists and psychologists are pretty low. The ratio is pretty low. That's the reality that we face every day. She got another relapse before the second autologous stem cell transplant, but she didn't want any chemotherapy. She was admitted for depression and bone pain. Psychiatry was consulted and treatment was changed to duloxetine from the classic SSRIs, and she was discharged with follow-up appointments. We got this news in Khalij Times. As you can see, myeloma did not kill her actually. So Shirley's journey ended. So the question is, what can we do as physicians to treat her? So the blood cancer is a big problem. The anxiety problems and depression are extremely common in these patients. Solid tumors as well. There are some of the references. This is one of the papers, one of the many papers we published. I worked with a psycho-oncologist in Seattle and Mayo Clinic. We published Damocles syndrome, and this actually pictures a graphic designer who was the sister-in-law of the first author of this paper, my mentee. That Damocles, the king story is that one of his court people wanted to become the king and was so jealous, and he said, "Okay, become the king." But when he became the king, the sword was always hanging. But one day he was not. He didn't actually sleep at all, and he was always fearing death and being killed by somebody. So this hanging sword of Damocles actually was described in the 1980s as Damocles syndrome, fear of recurrence of cancer. And this happens quite often, not just in cancer. You all see this all the time. This happens in many of the conditions, but this was first described there, and we actually published a couple of papers on this phenomenon. It's not in DSM-5 at the moment, but it's actually called the fear of recurrence of cancer. There's a lot of papers on why this entity exists and what can we do about it in cancer survivors. So the post-traumatic stress disorder is another thing she suffered from, and we did. I'm very blessed at SSMC. My nurse coordinator is super, and we look into the whole family. We talk to the whole family. We talk to the patient alone. We have PTSD screen as well that we do actually, because very frequently, I think this is one of the most underdiagnosed conditions in the world, because people mistake this as depression and anxiety disorders and treat them as such until the patients die or the grave. And they never know they had PTSD. The patients never knew, the physicians never knew, the patients were never referred for cognitive or CBT or any other therapy. But actually, the intrusive thinking, repetitive avoidance of the thoughts, cancer, thinking about cancer, anticipatory nausea when you enter the hospital at the time of chemotherapy, heightened arousal, you suddenly startle reflex is very, very high in these people, very high in fact, abnormally high. Changes in thoughts and feelings, lots of interest, enjoying activities, all these are symptoms of PTSD, especially the startle reflex and the avoidance of thinking. But you can't avoid that. A very, very classic signs of symptoms of PTSD, not major depressive disorder, because MDD has a very classic strict diagnostic criteria. So the PTSD scales are many. I would encourage all of you to take a look at this, in fact, because some of them can be very doable in the clinic, actually. And obviously, you need to be prepared that if you find something, then you should be prepared to refer. So you should always have that connection ready. But you should, if you start doing this, it takes a few minutes, by the way, and it becomes a routine part of the clinic, especially with these very, very complex patients coming from outside countries and have had a history of domestic violence. By the way, we do screen for the domestic violence as well. I can tell you that domestic intimate partner violence is much more common than we think it is, because we don't screen for it. That's why we don't find it and we don't refer. But in reality, once you get the confidence level, which the oncologists usually get, you will find out this is extremely, extremely challenging problem. And my chemotherapies ain't going to work until you solve the fundamental root cause of these social problems. So the questions are, and I'm going to end here early because we're late and we want to spend some time on discussion. Could anything be done to prevent Shirley's death? Depression was managed properly? Was the PTSD screen done initially? Does she have Damocles syndrome? Because some of the symptoms like startle reflex, nightmares, were very suggestive of fear of recurrence and PTSD both. Although these are different entities in DSM-5. Did financial toxicity play a role? Now we're writing another series of papers on social toxicity, which we define as a new terminology actually for cancer survivors. Do we provide holistic care? Looking at the chemical relapse, radiological relapse is one thing. But at the end of the day, if we didn't look at the social toxicity part, we didn't treat the patient well. And that's a reality that we don't. Because we're so focused on the war against cancer, we just forget the bigger picture of spirituality, what the patient's living for. And if you take the spirituality and put in your first note of history physical, that this is what the patient wants to live for. Now I can tell you that my patients have told me that they want to live for gardening. They want to live for one thing in life they want to do before they die, or family, or getting married, or having another kid, or graduation. I mean, you don't count the milestones as the degrees. In fact, it's the life events that are milestones that people live for. And that is spirituality, very simply put. It's not rocket science actually to document that in your notes, that this is what the person wants to live for, person like you and me. So depression, anxiety, medical problems, which are extremely common in our cancer survivors, require a lot of treatment. Could be genetic vulnerability. There's a lot of SNPs, and we're not going to go to psycho-oncology and psychoneuroendocrinology. The PNE is a big world, and I'm part of many groups in the US which actually are dealing with psychoneuroendocrinology literature. But the pathophysiology is complex when you put in the genetic vulnerability of polymorphisms and the psychoneuroendocrinology into the complex patient. The PHQ-9 PC-PTSD screens and GAP7 are important diagnostic tools. Remember, the screening tools and instruments are different than the confirmation tools, but a lot of things can be done in the clinic or in the inpatient setting, provided you have proper support system. All physicians must be comfortable in basic treatment of depression and anxiety, but they must know the Damocles syndrome, which is fear of recurrence, and the PTSD. Treatment involves biological, psychological, social aspects, and strong therapeutic relationship between physician, the patient, and empathy. We heard empathy many times today as shown to improve outcomes, hard outcomes like overall survival. You got to choose a mental health professional to start referring to. This is imperative actually, because at the end of the day, you want your patient to get better. It's not the cancer chemotherapies alone that are going to make them better. It's actually the whole group of people centered around the patient, which we actually term as patient-centered care at Mayo Clinic, which we're implementing here in the country, which all of you do actually, luckily, but we're trying to make it very, very formal and a top priority. So I'm going to end my talk mentioning that the artificial intelligence generated a fake picture of the patient, because obviously we cannot show the patient's picture, and this was an aging software, which actually developed her aging profile. So it's not a real patient. So with that, I'm going to end. I'm going to mention again 43 million survivors of cancer. Many of them have anxiety, depression, PTSD, and also they have a lot of fear of recurrence of the cancer if it's gone back. You know, actually, when I was doing breast cancer 10 years ago in New York, there was a lot of patients, breast cancer treatments ended. They're like, oh, we don't want to take out the line. We're so scared cancer's going to come back. And we're telling them, no, it's done. I mean, we're done with the treatments. You're cured, even after 1 year. But they're so scared, actually, it's going to come back. Nonetheless, I want to just leave the message that think about cancer survivors, these millions of people that we take care of. Think about your family members and friends who have had cancer in the past and are still survivors. Think about their mental health, think about their emotional health, think about physical health. And this is the only way we're going to think about holistic care and a patient-centered care. Thank you very much, and thank you for my great team, and thank you to the organizer for having me.